I'm excited to see that Carroll County brought their entire army here today. So I don't know how many of you are going to come up in front and talk, but the Carroll County Access Carroll program is a fantastic example of public-private partnership and working together between government and private sector treatment to make sure that there is a warm handoff and link to care. So I'm happy to invite Carroll County's team up to come talk. Tammy, just you, huh? All right, well, bring everybody up here.
Hello. So I just want to mention right off the top, I'm Tammy Black. I'm Executive Director of Access Carroll, and Sue Doyle, who is my large leadership partner, and many of the things you're going to be hearing today is out sick today. But I do want to also introduce Kathy Baker, who is the Deputy Director for the Bureau of Prevention, Wellness, and Recovery of the Carroll County Health Department, and Leslie McLeod, who is on the Access Carroll team as the Operations Manager, Manager of Clinical Operations. Sorry about that, Les. So I do have some notes so I can share some statistics should they come up, but I'm going to roll this rather quickly. I'm a fast talker, so I apologize in advance if things are a little quick.
All right, how do I operate?
So,
There we go.
All right. We are a very unique, I believe, partnership of public and private health. Access Carroll is a private nonprofit organization started in 2005 as a result of a needs assessment in 1997 that said basic primary health care was a problem for people who were uninsured. That was in 97. In 2005, we opened up as a part of another collaboration from a partnership for Healthier Carroll County. And the key partners in this whole thing who have remained solvent to this day is the Carroll County Health Department, Carroll Hospital, which is now a part of LifeBridge, the Partnership for Healthier Carroll County, who does assessments and data collection, and then the Carroll County government, who has recently been a more strategic partner, and they give us operating space at no charge. So I've done significant leasehold improvements to the space we now have of 13,000 square feet that enables us to do fully integrated medical, dental, and behavioral health care all under one roof. We also have, you can flip it, Kath. This is a quick picture that just shows how that works. So you got public health, private health, the partnership who did a needs assessment, and then Access Carroll, who was formed out of all of those needs. And we're just addressing daily what our county needs. This is a quick snapshot of the benefits of behavioral health integration into a primary care and dental partnership. And I want to stress dental because I haven't been to a meeting in the last 10 years where dental has not come up as an access need. So I'll mention some of the best practices there as well. This was a busy slide, but just know lots and lots and lots of outcomes. I believe that slide's also on the state website. For the behavioral health, and we've also have it in various forms of communication on our website, and then you all should be getting a copy, I believe, of today's presentations. This is also a very busy slide of all of our services that is kind of a big summary, but there's lots and lots of drill down within that. Primary health care, acute and chronic, behavioral health assessments and treatment, withdrawal management, detox, we use Suboxone and Vivitrol. With the medication-assisted treatment, overdose response education, we do naloxone training one-on-one with clients and as a county in our office once a month and more often as needed. We have family dental care from peds to Jerry's and everything in between. Medication assistance, so we do lots of acute and long-term medication assistance, which is a big deal for folks. I haven't met anybody yet who's got one only singular problem in their lives, and there don't be other wraparound services. So the rest of these things are wraparound care, including laboratory and radiology, referrals to coordination of specialty care, case management, care navigation, peer recovery support, public assistance application support, lots of education, and community resources. And it didn't show up on this slide, but we also have 2 state navigators for the health exchange who live on site with us. So if someone presents as uninsured or underinsured or just doesn't know what's going on with their insurance, we can drill down same day and get them signed up. Quick snapshot about our community. We're only 167,000 residents. After hearing the Baltimore City stuff, I'm like, okay, we're small little thing out there in Carroll County, but we have big problems, like everybody does. And so this is really probably a best model practice for the communities like us, who don't have that huge, massive population density, but we've got significant needs, and it can be replicated. We're doing pretty well on our insuredness. We've only got 25,000 who are estimated as below 200% of federal poverty. Very high case management needs. Huge dental need was in our county until we opened up our own clinic in 2013. And then 65% of all of our patients today have a behavioral health diagnosis. I'm also an ER nurse by profession, and so I have a really good idea of what happens in the emergency room. I did that for 10 years in Baltimore City and out in Carroll County, and then moved into my role at Access Carroll. And it was a perfect segue because you understand the patient needs that come out of the ED and how to connect them to the right services. So we do a lot of work with the emergency department and case managers to make sure that we can mitigate issues as soon as possible so they don't become crises, and we can deal with them in the outpatient world more effectively. So most of our folks come to us from emergency department referrals. And I will just say that there are very discoordinated, fragmented levels of care. Access Carroll pulls all that together to make sure they're getting their behavioral health needs met live time in addition to everything else. The average patient at our office is on 5 or more chronic medications. Just to give you an idea of what we're dealing with, you know how they say 20% of the population utilizes 80% of their resources? Within that 20%, we serve the top 5% of high utilizers in our county. These are some best practices. Apologize for the small print. We have a very strong no wrong door policy. I could talk all day about that, but just know if you want to know more about it, it works. We've spent years educating our community on this model, and it works. Lots and lots of collaborative efforts have gone into that, which means if you show up to my office and we don't do what you need, we wait while you're there and make the phone call for you and make it happen with a referral partner immediately. Public and private health living together in and of itself is very interesting. Two completely different worlds and cultures, policies, procedures, operating, funding, time off, all kinds of differences that we deal with, and we've been like the Brady Bunch coming together. We did a full integration with the behavioral health team at the health department last May. So it's been a little over a year of a tremendous success story. And again, I can share more if you're interested later. We have something that breaks down all the walls of communication barriers. And this is a very important point, I would say, in today's presentation. We have an integrated care agreement that was signed by the previous health secretary, Van Mitchell. It'll be going on 4 years ago. And this agreement allows us to legally communicate with each other, public and private health, sharing one EMR, sharing resources, public and private, together under one roof. That's human resources included. We're able to share billing processes and practices under one shared entity. And then we're able to make sure that we're serving those patients with the best approach to care from a public and private health model. So we're able to literally communicate and work together without all those HIPAA or CFR 42 barriers that typically present themselves in these kind of integrated care settings. That also connects with our hospital and with our health department at large. Because Access Carroll is a very interesting model of public and private health coming together, the hospital, actually I'm a hospital employee. I'm an in-kind gift along with 3 other full-time staff members who were a part of the hospital system. Because we're implanted there, we get direct referrals every single day. We get the overdose reports, we get the non-fatal overdoses, we get the folks without PCPs, we get the folks with all kinds of health problems who need our connection of care as an automatic referral system every single day. We reach out to those clients every day. Last year we had 1,100 of those such referrals that came through that having to do anything extra or special. We get it, we got their phone numbers, we got their diagnosis. We can drill into the portal in the hospital. Because we are hospital embedded staff, we have privileged access to that information, then we can confidentially distribute it within our internal team. And that's been a really highlight of our model of care. SBIRT is in all service lines. We've heard all about SBIRT today. I want you to know my dental practice is a model in the state of Maryland The federal government's been out twice to do a huge survey and interviewing of our team. We have 65% of all of our dental patients who are screened, our encounters, I should say, are screened. The ones that aren't screened for SBIRT are generally ones who come back multiple days in a row for like prosthetics or things like that. And it becomes a little bit of a weird thing to keep asking the same question multiple times in a day span. But just know that we're extremely successful. We've been able to get over 180 patients this past year into detox services through our dental program by the SBIRT screening. We also work with the University of Maryland School of Dentistry. Fourth-year dental students come out who are launching into their career in just months, and they're all trained in SBIRT. Dr. Perman is extremely excited about this model, and we'll be using this to expand within the educational world how we can screen patients at the educational level moving into full-time practice. And that's been also an interesting, I would say, best practice on the horizon. And, oh, I missed the whole 5-minute thing. I'm thinking, man, this is great. Okay, I apologize. Let me just flip through real quick. Oh, just real quick, 7-day-a-week. We just opened up on November the 11th, Veterans Day, to provide 7-day-a-week services. And we've been getting, so far I got 17 referrals from the ED, all of which we're entering into detox services. So pretty successful already. That was just in November. And I guess I'll stop there. So. Sorry.
Perfect.
Okay.
Thank you so much. We'll leave I'll give you the microphone just in case there are any questions, so you don't have to give it back quite yet.
Okay.
We wanted to stop you with enough time in case there were questions and leave
Okay.
your information up
It's
here
too
so
much to
people can
share in
contact.
10 minutes, so sorry about that.
It is a lot. The hope is really people take this and move on, take the next step and reach out. Yes, Ed.
I just want to, Timmy mentioned the 7-day-a-week detox, and the key piece with that was having the hospital cooperate with us, because we're getting essentially a warm handoff from the hospital emergency department, because the hospital said, well, we'll let the patients stay here because, thanks. Generally, we heard today that the hospital, the emergency department's not the right place for these people to be, and there's nothing they can really do with them there in the emergency department. So the hospital agreed that they would let the people stay there until Access Carroll, even though they have services 7 days a week, they're not open 24/7. So we need someplace for the person to stay until you can get that warm handoff, and the hospital's been helpful with that and getting those patients linked up with Access Carroll, so we're not losing them between the time they show up in the emergency department and the time they show up in Access Carroll. So that whole partnership thing there is a real key to that. That program, I think, is going to be very successful. It's already proven that way, and it's we're just getting started.